In this episode, I sit down with Kim Moscatello to go ahead and discuss her experience with Ehlers-Danlos syndrome and how you can become a better advocate for your clients that may be experiencing this condition. If you enjoy what Kim has to say, go ahead and give her a follow with the link in the show notes, as she is very active on Instagram and has a ton to offer. And of course, I would always love to work with you in the VIP membership, and you can get a 2-week free trial with the link in the show notes. But without further ado, let's get on to this episode. Welcome to the Evidence-Based Pilates Podcast, your home for science-based education made specifically for Pilates instructors. And we have an incredible episode in store today because I have Kim back on the podcast. Welcome back, Kim.
Hi, Adam. Nice to see you.
It's awesome to have you back. For individuals who haven't listened to your first episode, or are aware of your work, would you mind introducing yourself?
Absolutely. My name is Kim Moscatello. I'm a Pilates and a varied mobility instructor down here in New Jersey, towards the beach. I was on with you once before. I think we were discussing strength training and how it relates to Pilates. And I teach 100% one-on-ones these days, but I've been teaching now for about 14 years, various of all the things in fitness and Pilates alike. Studios, gyms, all the things. But I'm home now. This is my home studio, and I'm here in one-on-ones for 7 days a week.
Yeah, shout out to home studios. That was the best thing that came out of 2020 for me. With that, I invited you on today because I love to have individuals that can add knowledge on the podcast, because that's what this is all about, elevating the Pilates industry. And I reached out to you the other day to discuss your experience with Ehlers-Danlos syndrome, which feel free to correct me if I mispronounced it, because I've been working on it for 5 years. I don't know if it's good yet. EDS. I'm gonna say EDS, but I had to say the big one. It sounds smarter. EDS for the rest of the time. For listeners who have no clue what that is, because I had no clue even before physical therapy school, what is EDS?
So EDS is a genetic connective tissue disorder that can manifest in any number of ways, because there's 13 right now different subtypes of EDS. So they have a lot in common, but a lot of them can also be very different. But they affect, because connective tissue is literally inside, outside, and everywhere. It isn't just what people think of as like, oh, you can touch your toes really easily. It wraps your entire body. It's every organ system. It's every system in your body. So we have heart dysfunctions. We have gastrointestinal dysfunctions, nervous system dysfunctions. It's super fun. So it definitely is, and can be, much more involved than just the joint hypermobility, even though it can live just there alone. So that's where there's quite a spectrum inside and outside of EDS, but there definitely is a lot to it.
Yeah, 100%. That's why it's so important to have this conversation, because one of the big aha moments as a movement educator is recognizing that that EDS is a systemic condition, meaning multiple systems are affected, rather than that knee hyperextends and stuff like that. And so you mentioned that there were other systems involved, like gastrointestinal, cardiac. That could be like blood vessels, for example. I believe like low blood pressure could be a common symptom due to the elasticity of the capillaries and things of that nature. What are ways that EDS affects other systems outside of the party tricks of flexibility?
Yeah, well, I will say that on average, at least up to this date, they say it takes about 30 years, and it took about that long for me to get diagnosed. So a lot of us go through, and my particular brand of EDS is pretty poorly functioning. I'm affected in a lot of different ways. But it started for me in adolescence, and that's pretty common. You hear that a lot. It's also more common in females than in males by a great degree. So oftentimes towards like when the hormones are spiking and you start to get towards puberty, a lot of that will come out. So some of my first symptoms were being covered in stretch marks from my neck down to my knees, even though I wasn't gaining or losing any weight to look like a tiger had completely come at me. And then I had a stomach hernia that nobody, even the doctors, are like, how did that happen? She's like 9. Um, and I was put on my first restricted diet because I started looking pregnant every time I ate, and they didn't know what was wrong with me. So I started having endoscopies, and then I was passing out on the playground. They said I was making it up because whether orthostatic intolerance was a thing then or not, they just told my parents I was looking for attention. It goes like this. And then I had like head to toe pain and chronic fatigue, and they put me in therapy. Again, she's making up more things. My knees started rolling out, my ankles were rolling. It's just a ball that kind of keeps bouncing. It feels like nothing's related, but it's all related, but nobody tells you it's related. So you just think you're kind of crazy. And it goes like that for decades, unfortunately. Sometimes, and I've met so many people that have gotten diagnosed since I've met them, because I'll listen to them talk and I'm like, maybe you should go see somebody and suggest this. And we have to be the one to suggest, like, I think all of these conditions might be related. I have a heart condition. My throat collapses. I have massive TMJ. My jaw disconnects. But the dentist will say, oh, TMJ is common. And the cardiac will say, oh, well, people have mitral valve pull. Nobody is like, they're seeing everything from their one lane. So a lot of that stuff is really common. When you get the diagnostic to get diagnosed with EDS, it mainly functions on the Baden score, first and foremost. So it's determining your level of hypermobility in joints like your elbows and your thumbs and your knees, and whether your hands can touch the floor. And then beyond that, it'll ask questions like, how is your skin? Do you have an excessive amount of stretch marks? Do you have oddly long arms? Really random things you wouldn't think of, certain heart things. Is anybody else in your family like you? That's my mother. So there are certain things on there that like will get you diagnosed, but it also is missing a lot of big pieces that I think most people are like waiting for the diagnostic to get updated. Because in addition to that, a dysfunctional autonomic nervous system is right at the top of the list of one of our biggest problems. And I also have what's called mast cell disorder, which is also well known to go hand in hand with EDS. And mast cell disorder is you have mast cells also that go throughout your body. They release histamine. They're part of your immune system. And when they become hyperreactive, they can send you into anaphylactic shock just by smelling the wrong thing. So that's part to my life now. I can only eat very little things before my system completely tries to attack everything. So there are just a lot of stuff that goes along with EDS that you wouldn't think of. And so much of the autonomic nervous system goes hand in hand with the joint hypermobility as far as fitness professionals are concerned. So if we're starting to look at, like, I have clients or I have people that I'm working with that might be on that spectrum, what do I need to consider? It isn't just how their body moves, how we need to move it and why, but it's also how is this exercise being absorbed in their body? What is it going to feel like to them later? Because a lot of that is some of the nervous system manifestations too.
Yeah, there's a lot in there. In one place where I'll double click, because we can have a whole episode just on questions about that statement, is there's a severe gap, like 30 years to miss a diagnosis is massive. And some of the research that you sent me, by the way, everyone, there's a shit ton. That's the actual number, shit ton of literature in the show notes. It's science numbers. So there's a ton of literature to help you out, specifically on EDS. And one of the things is like a misdiagnosis can be up to 28 years, like you mentioned, 30, right? And so it does take, people just having an eye out and being familiar with conditions to try and connect dots. And in Pilates instructors, it's not your job to diagnose. It's not in your scope of practice. It's not in my scope of practice as a physical therapist to diagnose EDS. I almost went for the full name again, EDS. But we can put things together and be like I think it warrants a referral, and then that you want to collaborate, with your client and all of that. So you mentioned things that were important, like skin extensibility, just systemic conditions, like the things that you're mentioning, like fainting. That sounds like orthostatic hypotension. So that's changing positions. You get a drop in blood pressure. Hernias, that would be a stretching, right? Meaning these things come out and they sound very connective tissue, but of course we're in 2024 now, not in whatever year, uh, wherever it was. I grew up in the 90s. Things are different. We, wrestled in the front yard, things like that. So what are things just to double click on that? Like if you had like a top 5 list of like, these are things like if you hear all these clustered together, Pilates instructor, and your person hasn't been seen by a physician, like maybe provide insight into a referral. Like what would be those like telltale signs and symptoms?
Yeah, it manifests so differently in everybody. It's sort of tricky to say. Plus, I will say that almost every doctor can diagnose EDS because they all can see it from their own specific specialty lens. A rheumatologist, an immunologist, a PT, they all have the capability of diagnosing EDS. Whether they know enough about it to do so is another question. But we know as Pilates teachers that our clients come in and they banter with us a lot. We banter back, especially if you're in a one-on-one. So if you have somebody there and they're like moving and they're moving a certain way. And now listen, I've dealt with this my entire life. So I know kind of in terms of movement wise, like, that's sort of interesting what's going on there. And then while they're doing it, they're talking about all of these other health conditions that they're having trouble with, that they haven't been able to put together. And you start, the saying in EDS goes, when you can't connect the issues, it's your connective tissues. There's a lot of really silly sayings, but that's sort of the idea. It's like you heal all these little things. They all seem like they're not connected. And it's taken me a decade to convince my own mother that she has it, because you gaslight yourself over the years. I did the same thing, making up stories to people how I got hurt because a joint fell out of place. I was in cheerleading practice. That was bullshit. Nothing ever happened to me, but like things would just fall out. Nobody would believe me. So I'm just going to make stuff up and say that that's what happened. And my mom was like, no, those things, a lot of people have those things. I'm like, all 86, they have all 86 things. That's normal, Mom? Like, that's not actually normal. But after 50 years of it being your normal, you think it's your normal. Chasing doctors and them telling you nothing's right. You just, it gets used to like, okay, this is just me. I don't know why I'm this way, but this is just me. So for the clients, and there's been 4 over the last couple of years that have kind of like nudged towards some, just like, maybe go talk to somebody, or here's some literature, like maybe just to educate them on like, maybe this is what's going on with you. I'm not diagnosing you, but like maybe this could help, or go talk to somebody. And they wind up finding out some pretty enlightening things about themselves. And it can be really hard to swallow because 2 were almost 70 years old. And their absorption of that information was to get really depressed. Be like, wow, like all of these years have gone on and like I had no idea that that's what we were dealing with. And then some people get relieved, like, oh, that's great. Like there's actually a name for what's going on with me.
Yeah.
But I can remember being back in the studio maybe like 8 years ago, and I was more sheepish then. And there was a girl there that every single time she put her feet in the leg springs on the tower, her knees would, like, we couldn't get them back in. They would lock like inside out the second she would just put her feet in. And we would have to like, actually a couple of us help like manually try to help get her knee back in. She was so far spectrum, and she would leave. It would take her weeks to rehab and feel good enough to move again. She'd come back, stuff like that would happen again. And I was quieter then. And in the back of my head, I would want to go, there might be like a better thing for you than this. But like, you're not supposed to say that. And it's hard because like in reality, we think of Pilates, and I'm not saying that Pilates, first of all, I'm not saying Pilates is wrong or bad for people with EDS, because it's just so individual. You have to just see how things are tolerated in each single person. But it's low load, right? The resistance is supposed to be low load and gentle and controlled. So we feel like we should be able to do this, like of anything, we should be able to do this. But it's just not how our bodies work. There's no one thing that works, and there's no one thing that doesn't work. So it's like a fingerprint to find out what kind of activity we can tolerate and do, because it's really important to find, because we have to move and we have to get stronger. But it's a slippery slope and sometimes a really long journey to find what the best path forward for that is.
Yeah, and I mean, it's a tough pill to swallow for someone to find out they have any condition, such as EDS. And then it's also a tough pill to swallow as a Pilates instructor that maybe the Pilates we know how to teach isn't the best thing for the person in front of us. And that goes down to like person-centered care and like providing individualized service to everyone possible, which is easier to do in a one-on-one than like a group class of 20. Of course, one thing that I wanted to double click on before we move on to the Pilates based stuff is in one of the papers that you sent me. Let me read the title. It's just systemic manifestations of EDS. They actually found that studies have shown that 56% of people get a misdiagnosis and 70% undergo inappropriate treatments. So I just want to highlight that, like, those are staggering statistics, and how this can be mismanaged from a healthcare perspective, and from people like us, like, that are just like, let's try leg springs again, kind of thing. Like, that would seem like an inappropriate treatment. And so that's why these conversations are so important, because the if you don't know what something is, signs and symptoms, and how to help someone, like, there's no, like, that's how we get these statistics where it's like we're constantly like messing up. But with that, it in regards to this, before we double click on the exercise, I would like to get to the idea of just like someone who has like hypermobile joints, let's say, like an individual with hypermobility spectrum disorder. How is that different than EDS? Because someone would be like, oh, your knee hyperextends. That doesn't mean EDS.
Right. Well, I kind of display, and I sent to you also, so I'm not sure if you're attaching that in there, but what the diagnostic for EDS specifically is.
Yeah,
So
that's in the show notes, everyone. It's really good.
yeah, so you can easily fail it. And you can fail it also because there's such a lapse of amount of time between when somebody starts to be symptomatic and when somebody actually hands them that diagnostic, that a lot of that joint hypermobility actually goes down, because the progression in the illness is it changes. And over the decades, some of the hypermobility can actually decrease, even though
Yep.
all those systemic issues are even more so. So if somebody hands them that piece of paper to diagnose them, and then they look at their elbows and their thumbs and their knees and their back, and some of those things aren't that way anymore, now suddenly they fail and they don't have EDS, even though they do. So a lot of improvement needs to happen here. But I think it was in 2017 when they named the when they changed some stuff and did the hypermobility spectrum disorder, to try to capture the fact that, hey, you might fail EDS and you don't have it, but we're going to lump you into this other thing called hypermobility spectrum disorder, because at least we can say that you have HSD and you're somewhere along this spectrum of experiencing these ultra systemic individual problems, but you don't necessarily fit over here. So they don't know where everybody fits. So for anybody that they can't quite fit into the 13 subtypes of EDS, mainly we're talking about HEDS, which is the hypermobile one, but there's ones that are way worse. And then they just put you in the HSD category, but it doesn't necessarily mean that there's like a ton different. Many of those people probably have EDS. And even if you try to look at the statistics of like, well, how many people do have it? They're like, I don't know, maybe like 1 in 5,000 or 1 in like 50,000. They like literally don't know, because it's so underdiagnosed, or like you said, misdiagnosed. They just don't know, but they do figure it's a lot more common than what they've got written down right now.
Yeah, and that's where it's. I take a current stance with literature of don't get attached to statistics. Well, one, but understand trends, right? So there's 13 different types. My understanding is there's 13 types of EDS, and about 90% of them that are diagnosed are the hypermobility type. And so you're more likely to have that type, but the other types exist. That's still 10% of them, and then it splits between 12 different subsets to our current knowledge, which is less than what we would like. for this. But then you also have 56% of people get misdiagnosed. And then the people who, like, those are people who do get diagnosed. And the people that do get diagnosed, a lot of times it takes up to 28 years. It means we like the numbers suck. But you can understand the trend of like not enough people get diagnosed. A lot of people will have it, but not be diagnosed. And then the people who are diagnosed are likely to be a hypermobility type. That's kind of my takeaways in terms of concept. But for individuals that are unfamiliar with the Baton scale, well, one, there's the document in the show notes, but the Baton scale, you can Google it. It's super easy. It's a 9-point scale, from my understanding. Correct me if I'm wrong. It's two. You get 1 point per elbow if your elbows can hyperextend. You get 1 point per knee if your knees can hyperextend. I always forget if it's the thumb or the pinky that goes back. It's the thumb. All right. So it's if your thumb can touch your wrist, right? Yeah. Oh man, I'm not even close. And then it was like palms on the floor. Gosh. And then am I missing some? I think I'm missing some. Yeah. Yeah. So it's looking for so most people can't bring like their thumb on their wrist, for example. So it's looking for like abnormally high mobility. And this is important to recognize that someone might have like a joint specific hypermobility. Like my left elbow, I'm not going to get on camera, but my left elbow can hyperextend. But I'm also capped into the tight hamstrings club. Like I have the opposite problems with connective tissue. So I think it's important to also differentiate that just because a client has a one joint that can extend past our deemed normal for society doesn't mean that they fit in any of these categories.
Oh,
Whereas we're talking about
I mean,
connective
you can
tissue.
head to toe hypermobile and be fine. There's, you pick an athlete or a certain activity that just develops that hypermobility in a certain area. You can develop that to a certain degree. That doesn't mean there's anything, quote, wrong with them. So not everybody who walks in and she's like, wow, they're like really capable of doing these big range of motion things means that they like fall into some sort of medical category. So that's also a slippery slope. Yeah.
Yeah, no, of course. And so a big takeaway is these conditions are more than just joints, but we oftentimes see it as like joints because we work with movements typically in like a musculoskeletal frame. Now, going to like exercise. So if you had a client walked in and they have EDS, do we need to, like, how important is it to be really specific with them? Meaning provide them specific exercise rather than just like, let's do the original repertoire.
Oh, well, how would I say that? If someone actually comes in with a diagnosis of EDS, first I would be asking a lot more questions. What and kind of physical activity have you done thus far? How does your body respond to exercise? Do you have aerobic activity? Do you do weight training? You can really get down to the nitty gritty of what their body is capable of to get a picture of what might happen when you put them on the apparatus or the mat. Because I'm not in that boat. I started exercising daily at the age of 11. It's the only thing I can like go like this to myself for. Was I just understood that I needed to at least try to keep myself held together. If it was the only thing that was in my control, then I was going to try to keep myself held together. And that's unfortunately not the case for a lot of them that have like let decades go by, because if you start to have constant pain and subluxations and dislocations, now you're just afraid to move. And when you're afraid to move, then you don't move. And then when you don't move, everything hurts more, everything dislocated more. We're just on this hamster wheel that a lot of people never wind up figuring out a successful way to get off of. So then decades go by, they're outrageously deconditioned. Their exercise intolerance is one of like the fatigue top parts of their symptoms. You have like a whole like plethora of issues that you might get handed. So finding out sort of the benchmark of where are we starting from with you and your body? How does it exercise? Does it at all? And then maybe proceeds from there. So finding out what they do already currently and then working from that. If they've never used the apparatus before, my recommendation would be to stick with the things that are most controlled: a foot bar, a push through bar. Less variability is going to be better than more for us until you have a better picture of what their body can handle or control. The foot bar is going to connect their legs, so it's more closed chain. Like sticking with closed chain exercises until, like I said, none of it's, I never want to say that like anybody's body can't do everything. I try to get my body to be able to do everything. But until you're sure where they are on that, or if they aren't even sure where they are in that, you can never go wrong with staying more fixed. You can never go wrong with shrinking the range of motion to like 75%, just until you see how their joints respond to that pressure system. Because that's how I think of the springs and the apparatus. They're as like pressure systems to us. Of course, they're weight load, but in addition to that, they're pushing back on a lot of our joints. One of those clients that I mentioned with EDS, who's almost 70 and comes here, we don't even touch the apparatus anymore. We just go in the basement with weights, because even just footwork, she has what's called CCI, as do I. It's craniocervical instability. So the ligaments that connect our cervical spine to our skull are basically stupid and they just don't function. They're completely incompetent. So it won't look like our shoulders or our necks are necessarily doing anything wrong, but just the wrong kind of pressure. And it sends everything else completely awry. My vision, my hearing, I'm in bed for 3 days. So she could be up against just the shoulder blocks for doing footwork, and just the pressure that you receive from pushing from the springs on your feet. Her shoulders look fine. She sits up, she immediately wants to throw if she has to go home.
Should all clients with EDS not do footwork?
No. That's not, I'm just giving you an example.
I know, it's a provocative question.
No, you care? No, I'm not saying that at all. No, there's nothing that someone with EDS should not do, and hopefully they can do everything and not be uncomfortable. But this is why it's like you make a checklist. Like I literally have notebooks next to me when I'm working with those people. How's this feeling? Is this okay? I'll check in with them after. Let's add it to the list. Like I make lists of successful exercises so that we have something to refer to that we know we can build off of. A lot less question marks are better than just kind of like picking exercises and hoping that they land.
Yeah, no, this is awesome, because a lot of times when there's like, trying to formulate this thought well. So one criticism of an evidence-based practice is that it is like cookie cutter, right? If we don't have evidence for it, we don't do it and stuff like that. And I feel like that's a gross misrepresentation of evidence-based practice. Or it's really like it's really evidence-informed practice, because it's informed by evidence, but evidence-informed is not as sexy, right? So evidence-based rolls off the tongue better. It's marketing. So then with that, the top tier, are a big aspect of evidence-based practice when working with anyone with musculoskeletal pain would be client-centered care. And so that's what I keep hearing from you, Kim, is like you immediately, when I ask you a very like narrow question, you immediately go, no, I need to ask more questions, right? I need to understand this person more, their history, their feelings, their fitness level, and things like that. And I feel like we should do that for anyone, but definitely more for certain populations, such as EDS, where it seems like the threshold is different. Like for a lot of people, they wouldn't, even if they don't like footwork and it's uncomfortable, they're not in bed for 3 days afterwards. Where in this case, like that's a severe cost, is to be in bed for, I got shit to do, like in bed for 3 days. That drives me crazy. So it sounds like providing an individual approach is very important for these individuals. Now, with this, what are your thoughts on going to end range with an EDS population? Should we avoid it? Should we load it? Should we not give a shit?
It depends. It depends how much control and strength that person has developed inside of that activity and that weight load, more or less like you would say to anybody. But If it's a new activity and it's a new weight load, shrink it first. You can always work your way out, like start a smaller range of motion. It's working fine. They're doing fine. They can control it. They have a sense of that joint because we lack an extreme amount of proprioception, which has become part and parcel to like a big part of the problem. We don't know what our knees are doing. We don't even know where our feet are. So the sensation, like, how is all this landing? Okay, let's make it a little bit bigger. Do you still feel like you have it in control? I have videos of my mother that I've taken trying to do things just like side leg and strap stuff. And if she locks out her knee and just uses the ultra stretched tendon in order to move the leg spring, she can swing her leg forward and back very, very easily. If I ask her to soften her knee even like a half an inch, her leg drops to the ground and she can't even hold it up. Now my mom's almost 70, but what happens is like we walk her and she's only just starting her like exercise journey, but we just hang off of these overstretched ligaments and tendons in everything that we do, so much to the point that the muscle doesn't even lead the charge of the motion. And so when I connect her back into it, she can't hold her leg up. She suddenly can't handle the spring. She can only handle the spring if she's locked out and using the stretcher for tendon. So these are some of these like finer points where we go, oh, it's fine to lock out. Look, she has full control of it. Ask them to bend a little bit. Can they? So where we might think let's ask everybody to use their full range of motion. That's the hardest way. For us, it's often the opposite. Where it's hardest for us is when you make it smaller, because then you're asking us to come out of those connections and actually use the muscle in the middle. And that is something that a lot of us haven't done at all for years. And you'll watch the exercise then get really hard. So building out is actually doing a better job for them than asking them to hyperextend. And then if they have control of that, then go ahead and, lock out. It doesn't bother them. Do it all day.
So it sounds like your reasoning for potentially limiting the range of motion is to enhance challenge in a place where it hasn't been challenged in quite some time. Is that fair?
It's for safety first and foremost, because we want to make sure that they don't like dislocate or subluxate anything or have an injury or pain later. That's always first and foremost the reason. But as trainers, as people that we're also here to get these people stronger, we want to strengthen the area and the motion. That we actually want them to tap into their muscle strength. And because we're hanging off of these regions that like nothing is stabilizing the joint, we really have to get them like, at this point, I sit in ways I've so trained myself to do. But if I let myself I actually try to tell myself, just hang. Where are your actual shoulders if you let them hang? But because I've trained myself so well for them to just kind of be there, they're there. But that's not where they really are. But I've got my muscle to the point where it's like, no, this is where you stay. That's not my stable shoulder. My shoulder is actually really down here. My knees do the same thing. I can stand and look relatively normal. But if I let everything lock out, my knees go like this, my feet go like this. I've trained myself to be able to do that. But a lot of these people haven't been there. So the goal can be, let's train the stability in those regions more than the mobility that they already have, which can be a flip as a Pilates teacher, because people go in and you're like, I'm the mobility teacher. Like we make spines move and we make things move really big. That's not as important for us. Like we already do that. So less of the spinal stuff, honestly, most of the time, and teach their core the stabilization, help them to figure out how to work against the forces that they're often underneath the load of and they don't know how to control.
What are your thoughts on providing a core stabilization program for an individual with EDS? Like focus on multifidi and transverse abdominis and things like that?
Free weight?
Or anything. It's that stability, mobility concept.
Yeah, that was almost my answer. I would say that the best or one of the best things is just simple, transferable to life, free weight. Their corals will get stronger if we can get them to, and because like balance and gait and all of those things are also super challenged. It's best to look at like what kind of movements does this person need for their life that they're not able to do. And again, that goes with everybody, but really even more so for us. Can they kneel on the ground? Can they even get down enough, or do they just crumble there? Okay, well, let's focus there then, because knees are a big problem in terms of figuring out their spatial orientation and control. So stuff like simple lunging, medium range lunging, medium range squatting, but with weight, real weight that can help them to develop the muscle volume that they need to order to stabilize those joints. And as we well know, your core can develop quite quickly and quite well just handling enough weight. So that really is the most common sense way. Yes, of course, supine stuff, arms, legs, getting them to sense quadruped, all the things you know about core stabilization, but it can be super, super tricky. Ask them to do a cat-cow, they'll have the best one you'll ever see in your life. Ask them to plank, and you'll have 800 different things you're trying to put back into a straight line. You know, you push your hips down, and then their shoulders go up, and then their ribs pop, and you're just like pushing things up and down all day. So those are where you're going back to, okay, closed chain, walls are great. Any place where you can use props to help them to sense their body. Pilates was great for that for me in probably my late teens, early 20s. Just simple things like mat work that I started to do in college, where you think of it as ab work. But the big benefit to like the series of 5 for me was holding my own legs. I didn't know where my legs were. Like, we don't know where our legs were. So something just like single leg stretch. And like, I'm holding a knee and I'm seeing the other one move out. And I'm pulling the other one. Like, my hands themselves were holding on to body parts and sensing where they were moving in opposition to another one. So touch points are really, really helpful for us. I use them a lot. You'll see them in my videos, and that's a lot of the reasons why I do things like that. You're on the reformer. It's a foot bar. Lock up the springs and use it as a pressure system. Ask them to slide their leg across it. Ask them to put one under it and slide it from underneath. Push up into it. Give them sensory input to have a feeling of where their body is in space while still challenging them. If you put your leg under the foot bar while you're trying to do ab work and press up into it, that's really hard. But it also gives them a sensation of where that leg is. It's not just sort of like floating out in front of them. So you can get a little creative with the different levels of the apparatus without necessarily always using the springs in the traditional manner.
Yeah, and there were a few terms in here that I want to just double click on and clarify, because I'm thinking back to my early days, like listening to the Pilates Unfiltered as an undergrad student and not knowing words. So, what is like closed chain versus open chain? Like, how would you define that?
Oh yeah, I'm sorry.
That's okay.
The places where we can have our hands and our feet more pressed up against something. So, footwork is a closed chain exercise. You have your feet against the foot bar. You have your shoulders against the shoulder rest. We know where our body is moving. Open chain is now going to be the second that we have our legs up in the air. And now you're just moving your legs in and out, doing like core work. Open chain, your legs are just kind of flailing out. You have no idea where they are. They don't have a locked in point to press against.
Yeah. So just to put like even how do you say it? So to say the same thing in different words, because I think it's always really helpful. Closed chain is like when your feet are touching another object. We'll use hands work too, but we'll just use the feet for simplicity. Your feet are touching something, and the thing you're touching isn't moving. That would be like a 100% closed chain. And then like most of the mat work would be open chain for the feet, like one leg stretch or single leg stretch, the 100, stuff like that. Like you're not touching anything. And then there's this middle ground, which I've never found a good answer other than a supported open chain, because then there's feet and straps, right? And it's like, but I'm touching something and it's moving. That's very different feedback than something that's not moving, like the floor, a wall, a foot bar. And that messes with your proprioception a little bit differently. So I have first question is, what is proprioception? Like, what do we mean by that? And then second question is, how does open chain and closed chain make a difference?
Well, in terms of proprioception, your body's central ability to know where it is in space at all times, the room, or even just like yourself to yourself, like where is my hand in relation to my foot, or where is my body in relation to this door. Your ability to have proprioception is what allows you to walk through a dark room with the lights off. Right? Like I've been in this room before. I kind of like know where things are, put my hands up, not walk into something. Like that's your brain's ability to tap into proprioception. But they suspect because our connective tissues are so dysfunctional that plays a part that the brain isn't sending necessarily as functional signals to where those body parts are and how they're moving in relation to the joint. So we just don't have as much an idea of what's happening. Now, like you said, leg springs are obviously have a lot more variability than legs and straps because they can move apart. And that's where, in terms of when I said before, less options is better than more options, because legs and straps, now they can move around, but at least they're moving around together, which would seem like a better idea. But if someone has really poor proprioception and their joints lock out at different degrees, then their leg length is going to be different, and their pelvis, there's a lot of stuff in there, even though the straps themselves might be even. But now if you have them in leg springs and you're asking them to move them individually of each other, I usually can't even do that with a lot of people with EDS. There's just a lack of, like, it's like a circus. They have a very difficult time knowing how to control those swings.
Yeah, if anyone, because when you don't have EDS or a condition that impacts your proprioception, it can be hard to really create an accurate picture in our mind. And not that this is accurate, but I think it's helpful for anyone if you like if you know how to manipulate your proprioception. So then it's like, oh, this is like an experience of decreased proprioception. It's not the same thing, but it's the way you can feel it in your body. Is if you've ever had those like blue foam pads, those like thick blue foam pads, they're like you can get on my Amazon for like $20. But if you just stand on one leg on the floor and then you stand on one leg on the blue foam pad, you're experiencing decreased proprioceptive feedback. So it's a way that we can have empathy for people and just try to get another understanding. It's just like a thought that pops in my head of like, it's important to understand this. And then that can help you just make better decisions and support your client. So then it's just so subtle things like you're talking about with the feet and the straps, right? Like do we want them on a reformer, on a Cadillac, or do it at all? And then I also, something else that comes to mind, which I'm curious about, is like spring selection. Like, is this a population where you'd be like, let's do light springs? Or would it be like, no, let's go a little heavier for whatever reason? Like, how do you dictate your spring selection?
Well, I guess it would depend on the thing, but I always start lighter and then go heavier but quick. Like I'll just ask them to do a few repetitions and then check in with how everything's feeling. And then obviously what you can see with your own eyes. But you don't necessarily have to get to like through the entire set or through the entire session. Like I'll just let a few go by and be like, so how's this going? Can we go up? And work up from there. It's never my goal to necessarily be on the lightest spring for very long, but starting there is better than going up. And especially because now you're going to, let's say, if we're doing kneeling arms, something like that. Okay, so just to use an example, the experience is going to be, now we're talking range of motion. And since the weight load is going to feel to a certain degree more pulled or more pulled, depending on where their arm is being pulled, it might seem like the weight load is okay if it's like okay here, but it might not be okay here and it might not be okay here. So there's more questions than just like, oh, okay, that blue spring was fine-ish. Well, where was it fine? Was it like, can we go up? Like we might be better off going up and just being back in that 50 to 75% range than being on the blue or the light, excuse me, I'm using branded terms, being on the light spring and then going really big and seeing their elbows lock out and their shoulders and then they're feeling something in their neck. So it's not necessarily like light is better or heavy is better. I want to get their muscles stronger. That's always my goal, is like we need to get those muscles themselves stronger. So in reality, I always want to be on the heavier side, but I just need to make sure that we can get into a range of motion that can handle that and have them feel successful in.
Yeah, this continues to go back to like communicating with your client. Starting more conservative is what I'm hearing. Like starting more conservative, communicating with them, seeing what's working, what's not working, and then providing that information to make the best decision for the result you're looking for. And it sounds like a result or experience you're looking for is that they aren't like relying on the like extensibility of the tissues, or like the connective tissues, that they have a sense of where they are in space, and then providing them the feedback that helps optimize that. Like, is that
Yeah,
fair?
that is
Yeah.
absolutely fair. Yeah, that's absolutely fair. I mean, because we can move from everywhere too. If you start to work with more people with EDS, you'll like start to see it. But we can really move from everywhere. So you can ask them to do a bridge on the reformer, and they bridged up with their low back like 80% of the way. Like their pelvis almost didn't go anywhere. And then their chin, like, and you go, oh, okay, like, well, let's try to like move your butt up like a little bit too. And you have to like take their back down like the entire way. And then their ankles dip half. And I call it like the squeeze the toothpaste effect. But there's like, you're pushing it one way and then it's like shooting another way. You're going like, and you're like chasing it around, around and around. But if you just ask somebody to bridge up to like their highest spot possible, you do ask yourself, well, where did they do it from? Was that like, all right, maybe we're better off again going like down halfway and seeing if like the whole body can come up as opposed to just like a section of your spine. Yeah.
It sounds like
It can be definitely an interesting body to watch move.
yeah, it seems like a session that's really unique and fun to work with. Meaning it keeps you on your toes. And with this, I just want to bring this back because I want to ensure that the listener understands this is referring to EDS, which is different than hypermobility spectrum disorder or an individual that can just hyperextend their knees during footwork. So I just want to bring that back. But I'm also curious, Kim, if you're working with someone who like doesn't have a diagnosis of EDS, you ask them like the cardiac questions and the skin elasticity, they're negative, like they don't seem like they have EDS, but you're like, you got 6 out of 9 on the Baton scale. It's like you seem like you qualify for hypermobility spectrum disorder. Like, how would you work end ranges for that population if they're not EDS, but they are having this going on?
I'm not sure that I would necessarily do it super different. Definitely check about the subluxations and the dislocations, and that's like not on the menu. Because if somebody starts to have those, like they can happen really easily and repetitively. So if they've like never had a subluxation or a dislocation, you can at least be like, all right, well, even if they extend like really into that joint, it's never happened before. So still, we can be a little conservative towards that end range and checking in with how it's looking and how it's feeling. But I think a history there is something that you want to question before proceeding. But there are people that are really, really hyperextensive and still do have the proprioceptive issue, even if they don't dislocate and they don't sublux and they don't necessarily get ill. So some of those little tips can still be really useful in terms of helping them to tap into their proprioception and use their body with more stability and control, even if you're not necessarily worried about them hobbling out like to a hospital. It doesn't always have to go that bad.
Right. And so it sounds like, regardless of the human, right, we're giving an individualized approach. 100% agree with that. And I also like for an individual, especially like a shoulder or patella comes to mind. Like if people just have a history of dislocations, that's massive to know. Like for a shoulder dislocation, for example, it's usually males. But it can happen to females as well, especially like an EDS population. But just like someone who doesn't have a high mobility, they're not on the spectrum or anything like that. If they just have a history of a shoulder dislocation within, like, especially if it was a year ago, like, you need to be really careful with that shoulder, because they're going to go down a really slippery slope. So with that, it's just like taking the history and taking the time to just listen to your clients. Even if like you're supposed to get moving in the first session, get as much history as possible because they're telling you the treatment. Like you've got to gather that history. So if an individual has, they tell you, I had someone in the diploma actually of clinical Pilates, and we were presenting hypermobility content and stuff like that, and they spoke to me afterwards, and they were talking about history of, like, they have like, it was massive, like amounts of patellofemoral dislocations. That's the kneecap. And they're like, I'm not going to full range. Like, no way. I'm afraid I'm going to dislocate. Like, it's a great example of listening to the person. So like, I've thrown blanket questions at you, and you've continued to come back with, like, listen to the person, gather the history. It's very much an individualized approach. And I hope that the listeners really catch on to that. It's listen to your clients. If you're unsure, yeah, start conservative. I'm the biggest like move-in optimist and like just fucking load it person. But then there's also that's nice, but you also have to work with the person in front of you. And if they have a history of, patellofemoral dislocations, shoulder dislocations, you need to be very aware of that and act.
Jump in because I think we like also mentioned the exercise intolerance parts a little bit before vaguely, but
Yeah.
aside from the subluxations and joint pains and issues, I would say that's like number one to a lot of the problem. What is that? It sounds so benign, like exercise intolerance, but it can be where even just the amount of time that you're giving them a session, or how quickly you're moving through the exercises, or the postural positions that you're picking might not work for them. And you're not going to find that out until after, where they let you know the next day or the next 2 days that they were basically non-functioning after the session. So the class and session look like it went 100% fine, musculoskeletally, you played it conservative, you kept their ranges together, and then you hear from them and they weren't able to leave the house for 2 days. That's what we mean by exercise intolerance. And then you're like, well, hell, what did I do? I didn't do anything. It's not that. It can be so super sensitive, though. Then you have to think about intensity levels. You have to think about maybe it's a 30-minute session and not enough. Maybe we don't stand up. Honestly, you can think about this that anything that takes more energy as opposed to less energy. So there are certain clients I have that we, against all things that I love, lay down most of the time because that's the one that they can tolerate the best for the longest amount of time. The second I have them do something stand up, they're toast in like a minute, and then they might be like napping for a day and a half. Those are also things that we want to like, not just during the session check in, but afterwards. How did this work for you in the rest of your body systemically? Do we need to like adjust from there? For myself, who was like really pretty heavily trained in all things, in terms of progressing weight and strength, I would love it to be this line that goes forward, and it doesn't. Every day I have to change my own workouts as I go downstairs with a plan, and I have to go down 20 pounds and things because that day, that limb is not playing ball. So if you're a personal trainer and you have like, this is the weight you did this set on last week, I'm like, great, this week I'm doing it on 40% less. That's our path. And it's a really tricky one to be on as the person in the body, but it's so tricky to be the person that's guiding that human being, where logically you're like, you did this last week on that weight. Why do you have to do it on less today? Because we do.
Sounds like collaborating with your client continues to be insightful and checking in with where they are. And something that you're mentioning, it reminds me of a concept that we teach at Evidence-Based Pilates, and also Breathe teaches it, which is whenever working with individuals, it's with chronic pain, but also just with conditions, is to check in. It's called the 24-hour rule. You can check in like 24, 36 hours after a session, even if it's just someone who's coming in with chronic back pain, or in this case, EDS. Like check in with them and see how you did, because that's going to tell you about the dosage. Like you mentioned, if your client's in bed for 2 days afterwards, it doesn't necessarily mean that you did bad. You don't want to do that again, because it's bad for your business and it's bad for the person, but it gives you a lot of good information. And that's how I'd also encourage people to mention it to their clients. Like, okay, like be compassionate and be like, it's good information that tells us, like you mentioned, that maybe, instead of a 60-minute session, let's try a 30-minute session and see how you feel and things like that. And so this really goes down to working with the human. Like we're not just working with bodies, we're working with people, and our service is so much more than Pilates exercises. It's supporting that individual. And Kim, I'm just aware of the time, and for listeners that have hung in here with us, if they were to take one thing away from this episode, what would you like that to be?
First, I would say what you have said probably 7 or 8 different times is really the relationship that you have with a client with EDS. There's a lot of fear in movement for a lot of us because we're just so afraid of what's going to happen to our bodies afterwards or during. So feeling like that the person is working with us really understands how fragile we can both be and feel about movement, and that you're kind of in a metaphorical sense, like holding our hand and encouraging us and pushing us along and motivating us and all of those things, but also just being gentle enough to understand that there's so much involved and that a lot of us are just genuinely afraid of what's going to happen inside of that hour. So being as understanding as possible, and because we all have a lot of this 30-year-ish trauma of people not listening to us and just kind of dismissing us and just being like, here, take this pill. We really do need people to see us and understand us and want to help manage our life, because that's really all we can do, is try to avoid triggers and keep ourselves strong. So the best partner you can be for that client would be the best takeaway, I think.
That's an awesome takeaway. It was incredible to have you on the podcast again, Kim. You are always invited. And thank you, listeners, for taking the time to listen, become better instructors, and also better advocates for your clients. Until next time, have an awesome one.